Assalamu alaikum. This is Dr. Jaidaa Mekky. I'm an associate professor of neurology. Today I'm going to explain one of the very important neurological manifestations, which is called hemiplegia. The word hemiplegia means half. So when we say hemiplegia, we mean that the patient is complaining of weakness at one side of the body. So the upper limb and the lower limb ipsilaterally or on the same side are affected. Hemiplegia means complete paralysis, while hemiparesis means just weakness. Hemiplegia usually results from interruption of the upper motor neuron system pyramidal tract. According to where is the lesion, we will see the manifestation. And I think you have an excellent lecture of localization where this is properly explained. So if the pyramidal system on the right side is interrupted, the patient will start to develop hemiplegia on the left side. If the cortex is affected, I will see cortical manifestations like seizures or coma. The white matter has its symptoms. At the internal capsule, I will see a different picture. At the brain stem, I will meet crossed hemiplegia. And the last station at which I can see hemiplegia is at the cervical cord of the spinal cord. Any lesion below the level of the cervical cord will result into truncal affection and monoplegia on the contralateral side. So if I have a right-sided interruption of the pyramidal tract, I will develop left-sided hemiplegia. At the level of the spinal cord, usually if the lesion is on the right side, the patient will develop ipsilateral hemiplegia, not contralateral hemiplegia, and we will explain this at the end of the lecture, inshallah. Hemiplegia is affection upper and lower limb, ipsilateral. The word diplegia means that the two adjacent limbs are paralyzed, like bilateral upper limb affection or bilateral lower limb affection. This is called diplegia. And when it occurs in the lower limb, it is called paraplegia. If all the four limbs are affected, this is called quadriplegia. Hemiplegia by cause might be congenital or acquired. Congenital if the baby or the child is born with congenital hemiplegia, and acquired hemiplegia due to any secondary cause that might occur with age, like stroke, traumas, infections, or tumors. Usually some persons misinterpret that always hemiplegia is related to a cerebrovascular accident, or all cerebrovascular accidents are presented by hemiplegia. This is not necessarily correct. But when a cerebrovascular accident happens, so we'll take this example on the right side, the patient has an insult that resulted in left-sided hemiplegia. If this is due to an acute or sudden onset due to an infection or trauma, the area affected or the area where the lesion is will have something called the shock stage. The shock stage, when the brain area affected, makes a shutdown at all this region to allow the repair. So the shock stage manifests by loss of all the skilled movement at this area, loss of all the reflexes supplied by this area, and sometimes loss of sphincteric control or affection of the cranial nerves. The shock stage duration is quite variable according to what is the pathology, the age of the patient, and the extent of the lesion, and how long would it take to recover. Whenever the patient goes to the recovery phase, we will develop the classical hemiplegic posture where we have clasp knife spasticity, weakness of pyramidal distribution, which is flexion in the upper limb and extension in the lower limb. So if I have weakness due to a pyramidal lesion, the weakness will develop like the flexors in the upper limb will be stronger than the extensors, and in the lower limb the extensors will be stronger than the flexors. The third sign will be the exaggerated deep tendon reflexes, the absent superficial reflexes. Sometimes we have also urgency. These 5 signs are signs that I have a pyramidal upper motor neuron problem. Again, spasticity, weakness of pyramidal distribution, exaggerated deep tendon reflexes, and absent superficial reflexes, and urgency if the sphincters are affected. When we describe the clinical picture of a case with hemiplegia, Remember that we have an imaginary baseline. Anything less than this baseline is called negative symptoms. Anything more than the baseline or more than the normal is called a positive symptom. So among the negative symptoms, the patient might present with hemiplegia plus aphasia, loss of speech, or upper motor neuron cranial nerve palsy. The weakness is a negative symptom. Absent superficial reflexes is a negative symptom. Circumduction gait secondary to weakness in the lower limbs is a negative symptom. While the positive symptoms are clasp knife spasticity, where the muscle tone is above normal, the hemiplegic posture, the exaggerated deep tendon reflexes. Sometimes we can see hemianesthesia or hemiparesthesia, which might be a positive symptom. So whenever we assess a patient with hemiplegia after performing a full general examination, we should focus on the cognitive abilities, the motor system, is it affected or not, whether gross or fine motor skills, the speech and articulation, and if there is ataxia or not. Because these symptoms might occur also with hemiplegia in some cases. So what are the causes for a case of hemiplegia? One of the very important causes are the cerebrovascular accidents, whether embolic or thrombotic, head trauma, migraine. Migraine occurs with patients. Some patients develop something called hemiplegic migraine, where during the attack, the vasospasm might cause hemiparesis. This is usually transient, not permanent. Post-ictal, after some seizures, some epileptic patients develop TOTS paralysis, which is a transient paralysis where the seizure occurred. It's usually in the post-ictal phase for minutes or hours, and then it is relieved. So again, it is a cause of transient hemiplegia, not permanent hemiplegia. CNS infections, vasculitis, and multiple sclerosis might present as hemiplegia as a symptom. So if you see a patient with a transient hemiplegia, please do not jump to say that he is psychogenic. It might be a transient ischemic attack or migrainous patients. It might be post-ictal or secondary to an acute affection with multiple sclerosis. To assess the patient properly, we should take the history, the onset of this condition. Is it vascular? Is it with an abrupt onset? Is the patient known to be epileptic or not? Does he or she has migraine? Does he suffer from any demyelinating disorder? Or is there a space-occupying lesion in the brain with a gradual onset and progressive course for months or weeks? This might denote he has a CNS lesion. To localize hemiplegia, it might be cortical, subcortical, brainstem, or spinal cord. In the cortical lesions, I might find that I have signs of cortical dysfunction like aphasia or seizures or affection of the level of consciousness. If it is subcortical, it might depend on the vascular territory affected and the other manifestations. Does he has only hemiplegia or hemiplegia with ataxia or hemiplegia with hemisensory loss? If I have a brainstem lesion, then I have something called crossed hemiplegia where I have ipsilateral cranial nerve affection and contralateral hemiplegia. So let's imagine a patient coming with right-sided facial affection and left-sided hemiplegia. This means that the problem is in the brainstem. This is a crossed hemiplegia. And where does the facial nerve originate? From the pons. So this is a pontine lesion. And since the cranial nerves are affected on the right side, so this is the right pontine lesion. What about if I have right oculomotor affection and left hemiplegia? So the lesion will be the right midbrain. And accordingly, we have certain brainstem vascular syndromes. I doubt that you all should know all of them, but you should localize the patient's lesions where they are. The last station where I can see a hemiplegia is when I have a spinal cord lesion or spinal hemisection or Brown-Séquard syndrome. So let's imagine I have a lesion on the left side. If I have a lesion at the left side, this means that the hemiplegia will appear ipsilateral below this side. When I had cerebral or cortical or brainstem, I had right-sided lesion, I had left-sided hemiplegia. But when it's at the spinal cord, already the crossing at the brainstem has occurred. So if I have a left-sided hemisection of the spinal cord due to injury or metastasis or compression, right-sided hemisection affection of the spinal cord will cause below the level of the lesion, so it will cause an ipsilateral hemiplegia. But the pyramidal tract is not the only tract passing through the brainstem. What are the other tracts passing through the brainstem? If I have a lesion here, remember that the pyramidal tract is descending here on this side, on the left side. So I will have left-sided hemiplegia below the level of the lesion. And the deep sensory system and the superficial sensory system enters from this side. While the deep sensory system ascends directly here, the superficial sensations transcend to the other side of the spinal cord. So the deep sensations coming to this side at the lesion will be interrupted from coming upwards. So below the level of the lesion, I will have deep sensory loss, while I will have loss of the superficial sensations coming from the other side passing through this affected segment. So whenever we have hemisection of the spinal cord, we describe the lesion as having a lesion here, for example, above the level of the lesion, there is nothing. At the level of the lesion, ipsilateral, I have lower motor neuron manifestations due to the affection of the segment. Below the level of the lesion, ipsilateral, I have pyramidal signs and loss of deep sensations, while I have loss of the contralateral superficial sensations that will transcend through this lesion coming upwards. And the patient has usually a very funny complaint. He tells you, I have on one side hemiplegia and on the other side paresthesia or anesthesia. Again, do not jump to condemn the patient that he's psychogenic just because you don't know that it might be a crossed hemiplegia. It is a Brown-Séquard syndrome or spinal hemisection. If you have excluded all the organic causes and have examined your patient, you might say he might be a functional patient after excluding all the possible causes by investigations and that there are no signs on him by clinical examination. Because if you say that the patient is functional or hysterical or he is malingering, you might miss some patients during your practice. Remember always that hemiplegia is a symptom, not a disease. So the management and his treatment or her treatment is according to the cause of the problem. Thank you very much for listening.